All right, we're going to go ahead and get started. Thank you and welcome everybody to our webinar today. This is one of our ELLKAY Expert Exchanges, and we're going to enjoy hearing from our speakers on enabling remote patient monitoring through interoperability. Excuse me. And our speakers today. Oh, go ahead. I was going to say our speakers today, we have Lorenzo, Senior Vice President of Business and Development Operations at Higi, and Michael Wurm, Head of Product at 100+, and Gurpreet Singh, Vice President of Interoperability Solutions with ELLKAY. And with that, I'm going to go ahead and turn it over to GP to get the discussion started.
Yeah, thank you, Sarah. Yeah, thank you, Sarah. Want to definitely welcome everybody to this webinar. I'm really excited, for our panelists to join this. Really good folks out there that really know about remote patient monitoring. So what we're hoping to do today in terms of our discussions over here is kind of keep it informal. In terms of talking more about remote patient monitoring and what is remote patient monitoring all about? How are these organizations really involved with it? And, how can interoperability or, really help with the broader mission of remote patient monitoring? So I'm going to start off with basically asking Annie and Michael to quickly introduce themselves, give us a little background about yourself personally and the organizations that you're involved with. So I'll turn it over. Let's start with Annie, and then we'll go to Michael.
Thank you, GP. Good afternoon, everyone, and thank you so much for taking the time to join our session today. Annie Lorenzo, I'm our SVP of Business Development and Operations here at Higi. Spent my entire career in the telehealth space, working from large companies like MD Live to startup telehealth companies like Cirrus MD, running everything from client success to operations, helping standing up 50-state clinical networks, and really look at remote patient monitoring as the new frontier of telehealth and really extending that home to that care to the home. Work for an organization called Higi. We originally started in 2012, starting with 10,000 smart health stations across the US in pharmacy and retail locations. Originally, as kind of think of that blood pressure station, and then we've since evolved into really risk stratifying individuals, partnering American Heart Association, American Diabetes Association, American College of Cardiology to really do clinical risk assessments. And through the process of our company evolving, really started to look to how can we expand everything that we're doing in the community to the home. And a little over a year ago, we launched our remote patient monitoring company and solution called Higi Health. We are first and foremost, a 50-state clinical network with physicians, nurses, and nurse practitioners, really trying to meet patients where they are and extend our provider practice and provider clients with remote patient monitoring. And so really being that extension of our providers, doing end-to-end everything from device fulfillment, managing of patients to data interoperability, and really starting with that relationship first based approach.
Thank you, Annie. Michael?
Awesome. Thank you again for your time today, everyone joining. And thank you, Annie and GP for joining me on the panel. So I'm Michael Wurm, Head of Product at 100+. I'll rewind all the way, studied biomedical engineering, and I remember as my senior project, we built a pulse ox. So have been kind of in the remote patient monitoring space since that time. So from there went into strategy consulting and primarily was helping payers, and then had a few years at Facebook in their hardware division, working on AR, VR, and actually some health products, maybe somewhat surprising to the audience, but those are upcoming. And now run product at 100+, which is a remote patient monitoring platform, which, of course, RPM has taken so many meanings over the years, and even has a slightly different meaning for Higi. But with 100+, we focus on enabling providers to provision their patients with devices they can use at home so that the providers can have a data layer on which they can understand their patients' chronic conditions like hypertension and a blood pressure cuff, so that they can make better preventative care decisions and titrate medications more frequently than the snapshots when they come in for an in-person visit. So this is a new area of reimbursement that was started in 2018, and I'm sure we'll get into a lot more of those details later.
Right.
Yeah, I'm just super excited to be on today with so much wisdom from GP and Annie.
Wonderful. So Mike, since you started talking a little bit about the RPM program, can you give us a little background on the program itself? What is this program? It's been around 2018, can you give us a little background mechanics of how this works? What is the reimbursement, and basically how does the program work?
Yeah, absolutely. So Medicare in 2018 made a bet that if the physicians in the United States taking care of Medicare members had better data on the chronic conditions that the Medicare members had, then they could make better preventative care decisions and adjustments to their care plan, and that would actually reduce cost in the long term. And so they could pay a little bit upfront each month to provision this remote patient monitoring in order to get cost savings on the back end by reducing hospitalizations and other expensive care avenues. And so this is embodied by 4 CPT codes. The two foremost are 99454 and 99457. 99454 provides the physician for reimbursement for a technology service to get the device supply of daily readings from the patient or programmed alert transmission to the patient to remind them to take a reading. And then 99457 is reimbursement for the physician or clinician's time in reviewing the data that's coming off of the devices and doing the pattern recognition, drawing out insights, and communicating to the patient those insights and how they want to calibrate the care plan. And then there are 2 additional codes. There's one for the initial kind of patient setup and education. And then there's another one for if the physician needs additional time in a given month to really dig in with a patient and spend more time with them adjusting their care plan. So that's in the fee-for-service world. And then there's this whole interesting world of value-based care where it's quite different. And we're just dipping our toes into that. But I'll pause there and see if Annie wanted to add anything to that.
Thanks, Michael. So I think, when we looked at the involvement of remote patient monitoring, right, not a new concept. It was originally started as a hospital to home, right, hospital readmission play 30, 60, 90 days. And then, COVID hits. And really that's, to me, sparked into our organization, sparked the genesis of and the power of remote patient monitoring, which is how do you take especially seniors and seniors with chronic conditions and start overlaying preventative services to those seniors, right? So getting in front of our acute healthcare system. And when you really look at the way that our federal government, CMS, started to relax the codes like the originating site requirements and some of these others, it now really unleashed individuals and provider organizations to effectively bill and manage their patients by bringing devices and care management to the home. And so really looking forward to continuing to see how CMS and other payers that are coming along with CMS and are reimbursing for this service continue to push our healthcare system from acute care to a preventative care model and really hopefully expand those care management codes at 99458, which is the 20-minute increments you can spend with patients, which is really, from our perspective, where that effective management and adherence comes in building that relationship.
Yeah, so that's interesting that you brought up COVID, right? And I know RPM, remote patient monitoring, chronic care management, all of these codes have been there, for a while now. RPM obviously started off in 2018, but obviously COVID kind of really created a scenario where adoption and RPM really improved, right? Annie, what did you see in that sense? What has really happened in the last year? I think it'll be great to hear from you.
I think in my opinion, one of the only positives of COVID has been this forward spring of telehealth in general, right? I've spent my entire career trying to get the average consumer to understand the benefits of being able to use technology to connect to a physician and to really manage their care from home. And so COVID really forced individuals to think about delivering and providers to delivering care in a completely different and unique way, and leveraging technology to enable to do that. And so I think, that solves a problem, especially with acute care. But when you think about, again, the most at-risk populations with COVID, which was my parents, my grandparents, and being able to get their chronic conditions managed, their heart conditions, their diabetes managed, that really was forward thinking in terms of being able to push our healthcare system to evolve to serve individuals from the home.
Mike, do you want to add something to that?
Yeah, I mean, I'd say that similar to what Annie says there, COVID increased the motivation for patients to take control of their health because they were at home and doing a lot more introspection. And, we still are, depending on exactly where you are and what your day looks like. And, you're doing more introspection, you have less access to in-person care. And so, everyone was forced to be a little bit more motivated to take their health into their own hands. And so I think that when 100 Plus as an instantiation of that reaches out to a patient, after COVID, we saw that patients were much more responsive to us reaching out, and they've always had kind of the ability to respond and go take all their measurements, but they're now much more motivated to do so. And so we've seen that increase at every layer of the funnel for the providers and health systems that we work with, from sign up of patients and consenting to RPM services, all the way through adherence, and which is critical, and I'm sure we'll get into a little bit later.
Yeah, no, thanks a lot. I appreciate that. Actually, that is what I was going to bring up. The next topic was around patient engagement, right? And having come from this space, before I joined ELLKAY, I know that patient engagement has always been, a difficult thing to do, right? And so what do you guys do? And I'll start with Annie on this, right? How do you actually help out with patient engagement? And then another question related to that is, around the fact that how do you keep people engaged for longer than 6 months, right? Because what I've seen over here is the number of months that they're engaged is probably sitting somewhere between 4 to 6 months, after which they tend to drop off. So how do you actually keep that going? Annie, I'll start with you.
Thanks, GP. It's a problem that we wanted to tackle first and foremost when we set up our company, which is why you heard me start with our clinical model and not our technology first. And so what we really looked to do was to build that clinical model, and our dedicated nurse care managers, that's an extension of provider groups. So even though we have the infrastructure to prescribe, diagnose, alter treatment, we won't. We draw a very clear line in the sand that they're not our patients, they're yours, they're primary care and specialty care, but we become that extension of that care team from the home. And that starts with a simple and easy, seamless onboarding process, from engaging the patient that this is potentially a covered benefit with upfront financial responsibilities, so they're very clear, to overnighting the devices, which we use a multi-use cellular SIM card, so cellular enabled devices. We find that using that versus Bluetooth really enables and makes that more seamless. The end result for our seniors is that you plug in a battery, turn the devices on, and it automatically starts transmitting. But most importantly, we assign a dedicated care manager, which is a nurse or a nurse practitioner. And so when you get assigned to Tiffany, for example, on Monday, you're dealing with Tiffany on Friday, and she's the one that's helping you adhere to your care plan, take your biometrics, really ensure that if there is an issue, that we're communicating back to the primary care physician or that specialty care. We'll just use kind of a real patient example, because to me, it's the best way to summarize exactly how we look at patient engagement. We had a senior on our platform who's blood pressure kept spiking, and our nurse care manager was calling him, really trying to understand what was going on. He was insistent that he was taking his medication appropriately. After further discovery, and we knew he suffered from mild dementia, turns out he couldn't actually get into his primary care to pick up his new prescription for his hypertension medication. So he had turned to an older version of his medication, which was a different formulary that was actually causing his blood pressure to spike. And so when we figured that out, our nurse care manager got him a next day appointment with his primary care. We transferred the data over through a seamless integration. And part of that data is we summarize that information. We make it contextualized and actionable for a provider. So it's a summary of data that reduces the signal to noise ratio that you get a lot of times with RPM companies. Once we got him in with his primary care, we arranged a ride there, arranged a ride to his pharmacy, got him home, got him back on his medication. And guess what? Now he's back in range. And so when you think about putting that powerful power first and not just looking at it as a point solution, but a full technology suite, that's what we're doing. And so our data, over a year's worth of data, is showing 97% compliant and adherence to our care plan. And that's not 30, 60, 90 days or 6 months. That is over a year, and that's for that relationship.
No, that's impressive. That's truly impressive. Michael?
Yeah, I just want to comment that that's an awesome story. And I love hearing the patient example and how you're really able to make that patient's life better and enabling the provider to do so. And so, thinking about 100 plus and how we manage engagement with patients, which I think is a continuing challenge for the industry. It's first helpful context is that 100 plus doesn't actually do any of the monitoring. And so when I went through the CPT codes earlier, we really enable providers with the technology layer, but we don't do any of the review or engagement with the patient synchronously to review their data. We of course have a customer support team to help them with more mechanistic challenges that they're having with their devices and with the platform, but never to kind of do clinical review. So we're really focused on enabling the provider. So that's kind of a different tack at it. But I'll start. I think there's two properties of our platform that are really important to touch on when it comes to engagement. The first is very similar to what Annie had mentioned, in that we have a zero-click setup for the patient. So the way that it works is a provider is sitting in the office with a patient, or they enroll them remotely, and they say, hey, this patient has hypertension. I'd like to provision them a blood pressure cuff, and it will drop ship it directly to the patient's location, home, and the provider doesn't have to manage any inventory. And then again, similar to how Annie mentioned, all the patient needs to do is turn on the device, take a reading, and it's transmitting cellularly back to the provider's chart for that patient. And so it really is zero click. It's the same device and form factor that they've used for their entire life. These devices are actually not novel in how they measure it. It's really novel in how they transmit it and the software layer on top of it. So that's the first one, and that is critical for getting 0 to 1, right? Like, so much of the engagement drop off is actually at day 0. And then after that, we have built out an AI based SMS virtual medical assistant. And so similar to what Annie mentioned, we serve as an extension of the practice, enabling them to scale their coordination with the patient. And so the SMS system, we call her Ava, and she for each practice is actually part of their practice to the patient. And she is able to answer all those kind of simple questions, but also able to increase their motivation, because we find that in order for a a patient to change their behavior. In this case, we want them to take a reading to increase the temporal resolution of that layer on which the provider can make preventative care decisions. They need to have motivation, ability, and a trigger. And so they have the ability, right? They can take a reading. And the question is, do they have the trigger? Are they remembering to do it? And are they motivated to do it? And so we use this SMS system to always provide the trigger and then increase motivation when we find it necessary and when the AI system finds it necessary. So we've seen that increase patient engagement significantly as measured by the number of days that they're actually taking a reading. And the awesome part about the way that the CPT codes are structured and really wise by CMS in our opinion is that they count the alert transmission as part of the monitoring. And so even if you aren't able as a provider to get the patient to take a reading on a given day, you can actually count that toward your monitoring because you're trying. And AVA enables you to scale to do that because if you have a practice of 1,000 patients, you might not be able to call them every day. But using our system, you do have that scale. And then we do have a patient-facing web app where they have very simple authentication via just date of birth and name so that they can go see their historical data. So that return of information we find is really important for a patient so that they can go back and look into their biometric history. And then, we're always experimenting with new things. We're starting trivia where we'll be sending daily trivia. We'll see how that lands. And yeah, it's ever evolving.
Thank you. That was really detailed information. Thanks a lot. So let's talk about data, right, and interoperability. Because obviously, you're trying to make sure that patients are getting alerted, providers are getting alerted, providers are seeing the data in their EMR systems, and you're trying to maintain that seamless sort of data transition, right? So Annie, I'll start with you on this one. What are you doing from a data interoperability perspective? What is the role of bidirectional data integration, right? That you think helps, kind of build up the efficiencies across all stakeholders?
Yeah, I think that's a great question and an ever-evolving problem, right? Is the data interoperability. Look, if you take a step back for a second and look at the RPM space and how it's evolving, and there's a bunch of companies that still do kind of the point solutions with the technology. There are companies that really look at this as a clinical delivery model and a patient-centered approach. I mean, if you look at other companies in the organization or in our industry, like Beta Health or Assure Health, right? They're taking that the patient-centered approach, right? And really, we look at, similar to some of these other companies, that data interoperability starts with meeting the patients where they are, and that's how we generate that high-quality data. And so when we talk about our data interoperability, we actually look at a pyramid of data, right? And you've got self-reported data, you've got transmitted data, and then you've got data being transmitted into an EMR, but who's actually vetting that data and making it clinically sound and contextualized, right? So it's actually actionable for a provider to know, do I need to act on this patient based on the reading or what's going on at home? And so when we look at data interoperability, a real example I use is we had one of our patients, part of his care plan and adherence was to start exercising more, right? Going a little light jog or walk. And he happened to be taking his blood pressure right after that. So his blood pressure was spiking at a normal range. If we would have just sent that trigger or alert back to his primary care, that wasn't a necessary action for his primary care to be following up on. We actually were able to contextualize that data and understand that no need for primary care intervention, right? Don't take your blood pressure right after you run. It's really figuring out, from at least our perspective, how you push and pull data in a very seamless way. And so the way that at least we built our system is we are device agnostic. So if you're taking a blood pressure from our cellular device, if you're using one of the Higi stations, if you've got a device that you transport with you, we're able to tie that back to the patient and then contextualize and take in all that data, ingest it, normalize it, and then push it back out, whether that's through an HL7 or Fire feed, All of that obviously is through ELLKAY, which I think is very important to have that one pipe in and out and really ensure that we're working with good partners like ELLKAY that allows us to do that real time. But I think if you take nothing else away from this, it's really ensuring that you're not just pushing data and alerts to primary care, but you're also making that data actionable and contextualized for not only the patient, but for the providers that are maintaining and trying to manage their patients.
Thank you, Annie. Michael, I'll let you kind of say something for about a minute, and then we'll kind of open it up for questions from anybody out there. Michael.
Perfect. Yeah. So, interoperability, and especially using ELLKAY as the solution for that is what makes it possible for us to get the data back into the EHR. And so that's critical for the patient journey, as Andy said. And a few of the use cases that we're using it for: revenue cycle management, so putting claims into the provider or biller's queue, for enabling us to understand who we might be able to enroll in RPM in the first place. So getting the practice's patient list ongoing and, catching any mutations to that. And then putting the RPM data back into the EHR with some chart abstraction and ensuring that is there so that all the providers that use that EHR can have that context. And then lastly, one of the ones that we'll be doing a little bit further out is scheduling. So using our SMS-based system to turn an RPM incident with a patient into an actual in-person appointment with the provider.
Okay, thank you. So we're running really short on time, right? We've got less than a minute and a half over here. There's one question that popped up, is the fact that which type of organizations, are the ones that should be using or looking at RPM, right? So what type of provider organizations? Who wants to go first? Let's go with Annie. Yeah.
Okay. I think really any provider organization that wants to better effectively manage their patients, both from a fee-for-service perspective, because it is additional revenue, right? If you can effectively manage your patients and take some of the burden off your physicians, like we're able to do, you can get up to $120, $140, depending on how much time you spend with them, but also very risk-bearing, right? Those taking risk from an outcomes perspective. If you set up an RPM program the correct way, right, there's significant downstream impacts to those risk-bearing organizations.
Yeah.
Michael, there's a question that's for you. I think somebody's asked this: is how does your company ensure proper outcome metrics and escalations with the AI bot and no direct clinical oversight?
Yeah, so the AI bot doesn't actually answer any clinical questions or have any clinical engagement with the patient. The AI bots today is constrained to reminding the patient to take a reading when they've fallen out of adherence, and she can answer very simple questions about the RPM program. So at this point we are staying very much below the line of clinical engagement via that tool. In the future, will enable clinicians themselves to actually take over the SMS channel and have that engagement. So that's how we ensure it. And just to answer the question, I think it's all organizations should really be focusing on RPM, given the patient outcomes that we're seeing. We're seeing obese patients lose clinically meaningful amounts of weight. Diabetes patients lose clinically meaningful amounts of blood glucose. So it's really all provider organizations.
Okay, so we're on time over here. We're up on time, but I'll give you guys 30 seconds for any last words that you want to leave the panel with, or the audience with. I'll start with Annie.
Thanks, GP, and thank you so much for taking the time here today to listen to us. I think if you take nothing else away from this, it's remember who the patients you're serving: parents, grandparents, the seniors, right? And you throw a bunch of tech at them, they're not necessarily going to be compliant and adherent. And then help your providers as well. Be preventative and really be thoughtful with the data and the experience, and you'll have significant outcomes like we're seeing.
Thank you, Annie. Michael.
Awesome. Yeah. Thank you again for everyone's time here. And I think, RPM has a really strong ability to improve patient outcomes for patients with chronic diseases. And again, regardless of the type of provider organization that you're in, it's really the time to implement RPM is now or yesterday. And so we're excited to partner with your organization or help you learn about how RPM works.
Thank you. Thanks a lot. Thank you, everybody, and thank you to the attendees on this good, amazing discussion that we had, an informal one. So thanks a lot, everybody. We'll talk to you later.